Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Kristen Rosenthal. Today's episode is the first in a series of 3 and features Dr. Rebecca Heist, an Associate Professor of Medicine at Harvard Medical School and Mass General Hospital in Boston, and Dr. Helena Yu, Associate Attending at Memorial Sloan Kettering Cancer Center in New York. In this series, they will be discussing new clinical trial data on the use of HER3 targeted therapy for patients with advanced non-small cell lung cancer, including recent data presented at the 2023 European Society of Medical Oncology Annual Congress held in Madrid, Spain. This episode is part of a larger educational program titled Congress to Clinic: Continual Evolution of HER3 Targeting in Non-Small Cell Lung Cancer, with expert perspectives on clinical advances and practical application. For more information on Dr. Heist and Dr. Yu, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now, let's get started with our first installment as Dr. Yu talks about the rationale for HER3 targeting therapy in non-small cell lung cancer.
Hi, everyone. Good afternoon. I am going to go over some of the initial data discussing HER3 as a potential target for cancer treatment. Okay, so HER3, which you may or may not know about, is a gene within the ERBB or HER family. And this family is HER2 and HER4, which is actually EGFR. So HER3 is not a driver mutation in and of itself for lung cancer, but it plays an important role because it heterodimerizes or binds to HER2 and EGFR and promotes oncogenic signaling. So it's something that kind of indirectly affects oncogenesis and cancer signaling. It is expressed in these different tumor types. And so there are certain tumors like colorectal and melanoma where we see very high rates of HER3 expression. Lung, where the majority are about half of cancers, and I think recent data suggests that this is even higher, express HER3. So if HER3 is a cell surface receptor, there are ligands that end up binding to HER3 to cause this activated signaling, and neuregulins are the primary activating ligands for HER3. So binding of neuregulins leads to activation and heterodimerization, and then this downstream signaling. And so one way that HER3 can be a little bit more directly involved in oncogenesis is with these energy 1 fusions. And so basically energy 1 fusions lead to aberrant expression of the energy 1 ligand, and that leads to oncogenic signaling. So one tumor type that might be eligible for this HER3 targeted therapy might be cancers that have energy 1 fusions. They're quite rare, but similar to NTRK fusions or RET fusions, if they are identified, they certainly could be potentially targeted. Energy 1 fusions in particular are seen in colorectal cancer, pancreatic cancer, lung cancer, cholangiocarcinoma, ovarian cancer, and sarcoma. So there are some ongoing studies are looking to enroll patients with these energy 1 fusions. So akin to HER2 expression in breast cancer, there is a desire to measure HER3 expression and see if this correlates with response to HER3-directed therapy. And so the way that we measure HER3 expression is through immunohistochemistry, so antibody-based staining similar to HER2, with an IHC score of 0 having near no staining of cells, and then with IHC 3+, strong staining in greater than 10% of tumor cells. And so this is tough as it is in other cancers where there is a lot of variability among the different pathologists in terms of grading. And so one way that we have tried to make this a little bit more both quantitative and reproducible is using an H-score. And so a lot of the clinical trials have looked at H-score of HER3 expression retrospectively to see if this correlates with response. But because it is not used as a biomarker for these HER3-directed therapies at present, it's not recommended currently as a biomarker to utilize. And again, clinical trials of HER3-targeted agents really haven't used HER3 expression as an inclusion criteria. We'll talk about EGFR mutant lung cancer in particular during this conversation because some of the initial HER3-directed therapies are being looked at in this patient population because there is preclinical data that suggests that increase in HER3 expression helps drive resistance to EGFR-directed targeted therapy. And so the thought is that HER3 heterodimerizes with EGFR and HER2, but perhaps one way that cancers can get around blocked EGFR signaling is utilize MET receptor. And we know that MET amplification is a common mechanism of resistance to different targeted therapies, but HER3 and MET can interact, and then that can lead to sort of a bypass signaling pathway that leads to continued growth and survival despite EGFR-directed therapy. A group looked at HER3 expression before and after EGFR-targeted treatment, and levels were higher in the post-treatment setting versus the pre-treatment setting, suggesting that HER3 expression has a role in resistance to targeted therapy. And so there have been many investigational agents that target HER3. The first kind of wave of treatments were actually HER3 monoclonal antibodies, including patritumab. A lot of these as single agents were really not determined to be effective. And so as the field has evolved, there has been more interest in looking at antibody drug conjugates against HER3. I will be talking about patritumab deruxtecan, and Dr. Heist will talk about some of the other ones that are in active clinical development. An ADC is a type of a hybrid targeted chemotherapy that has three components. And so there is an antibody component, that's the monoclonal antibody against a specific antigen. And the tumor antigen is often one that is, of course, abundant in tumor cells, but not in normal cell tissue. So this kind of localizes these ADCs to tumor cells. There is a linker that binds the antibody to the payload. And then the payload is a cytotoxic drug, a chemotherapy molecule that is highly potent. And the idea is it has enhanced potency, but it is directly delivered to the cancer cells of interest, leading to less toxicity. And so how does an antibody drug conjugate, what is the mechanism of action? ADCs are administered intravenously. They're in the vasculature. And once they reach the tumor, they bind to the antigen. So for these HER3-directed therapies to HER3 on the cell surface, they're internalized as an ADC complex still. And then once internalized, that linker is cleaved, usually in the lysosome, and then that allows free drug to circulate within that cancer cell, leading to apoptosis and cell death. And if you've heard of bystander effect, that is when some of the loose payload gets distributed prior to entering the cancer cell, and that can lead to cell death of additional cancer cells, but also sometimes normal healthy cells as well.
Thank you very much, Dr. Yu, for your clear explanation on the rationale for the use of HER3 targeted therapy in non-small cell lung cancer. And thanks to you, the listener, for joining us. As a reminder, in the next two installments in this series, Dr. Heist and Dr. Yu will discuss key trial data on various HER3 targeted treatments and how to manage adverse events associated with these agents. To view the full program, Congress to Clinic, Continual Evolution of HER3 Targeting in Non-Small Cell Lung Cancer with expert perspectives on clinical advances and practical application, and to download a highlight slide set including the various studies associated with this discussion, please click on the link in the show notes. And as always, thanks for listening.